Welcome to the Deep Dive. We're your shortcut to getting really informed, and today, well, we're looking at something pretty significant in cancer treatment.
We really are.
We promise a faster way to grasp a key medical breakthrough, maybe even a turning point, for patients with a specific, tough kind of lung cancer.
Right.
It's about how a newer drug is, really changing things, especially when it comes to the cancer spreading to the brain, which is always a huge concern.
Absolutely.
We're focusing on non-small cell lung cancer, NSCLC, but specifically the ALK positive type. It's relatively rare, maybe 2% to 5% of NSCLC cases.
Yeah, not a huge percentage, but critical for those patients.
Exactly. And for them, a class of drugs called ALK tyrosine kinase inhibitors, or TKIs, they've become the standard approach.
And that's where our focus lies today. We're zooming in on two specific TKIs. First, there's Lorlatinib.
Okay.
That's a third-generation ALK TKI. It's known for getting into the brain effectively and covering a wider range of ALK resistance mutations. That's super important for keeping the cancer under control long-term.
Makes sense. And the other one?
The comparator drug in the study we're looking at is Crizotinib, an earlier generation TKI. And this whole deep dive, it's built around a recent study, a 5-year follow-up, actually, which gives us a really good look at the long-term picture.
Right. So here's the mission for you listening. We're going to unpack these 5-year results from the CROWN study, and we're specifically digging into a what they call a post-hoc subgroup analysis. This part looked just at Asian patients who had advanced ALK-positive NSCLC and hadn't been treated before.
Okay.
So the setup was pretty standard for these trials. Patients were randomly assigned, sort of a 50-50 split.
Yeah, 1-to-1.
One group got Lorlatinib, 100 milligrams once a day. That was 59 patients. The other got Crizotinib, 250 milligrams twice a day. 61 patients in that group.
And they followed them for a good long time.
They really did. The median follow-up for Lorlatinib was over 5 years, 62.4 months. For Crizotinib, it was 55.1 months. So plenty of time to see how things played out.
Definitely gives us solid long-term data.
Okay, so with that framework in mind, let's get right into the results that really jump out. Progression-free survival. Here's where it gets really interesting.
It really does. The PFS findings, well, they're quite something. For the patients on Lorlatinib, the median progression-free survival was not reached.
Not reached. Okay, let's unpack that. What does that actually mean in practical terms?
It means that even after 5 years of follow-up, more than 50% of the patients taking Lorlatinib hadn't seen their cancer progress or hadn't passed away.
Wow.
So they couldn't even calculate an average time yet because so many were still doing well. Think about that, the potential for years free from progression.
That's a huge difference compared to the other group, right?
A massive difference. With Crizotinib, the median PFS was just 9.2 months.
9 months versus potentially years.
Exactly. And the hazard ratio, which kind of measures the risk reduction, was 0.22.
Which means?
Roughly speaking, Lorlatinib cut the risk of progression or death by about 78% compared to Crizotinib. That's a dramatic improvement. 78%. And those 5-year actual rates really tell the story, don't they?
They absolutely do. At the 5-year mark, 63% of patients on Lorlatinib were progression-free.
63%.
Compare that to just 7% for Crizotinib.
7%. That's stark.
It is. It suggests we're shifting from just managing a fast-moving disease to possibly, treating it more like a long-term condition for these patients.
And this could actually be the longest PFS ever reported for advanced NSCLC patients, period.
It potentially is, yes. Certainly one of the longest, demonstrating really durable control.
Okay, so PFS is impressive. What about shrinking the tumors, the objective response rates?
Also a clear win for Lorlatinib. The ORR was 81% with Lorlatinib.
So 8 out of 10 saw their tumors shrink or disappear?
Right, compared to 59% for Crizotinib. Still decent, but a clinically meaningful improvement with Lorlatinib. Okay, let's unpack this. We mentioned the brain earlier. Why is the brain so critical here for ALK-positive patients?
It's a major issue. ALK-positive NSCLC has this high tendency to spread to the brain. Brain metastases are really common.
And devastating, I imagine.
Absolutely. They can cause serious neurological problems, really impact quality of life. So controlling the disease in the brain is crucial.
So how did Lorlatinib do there? Intracranial efficacy, they call it.
Yeah, IC efficacy. So looking at patients who already had brain mets when they started the study, Lorlatinib achieved an intracranial response rate of 69%.
69% response in the brain.
Yes. And what's really impressive is that within that group, 69% achieved a complete response in the brain. Their brain metastases became undetectable.
Wow. And Crizotinib?
Only a 6% intracranial response rate, and just 6% had a complete response there. Very, very different outcomes.
And the time it took for the cancer to progress in the brain.
Also telling, for Lorlatinib, the median time to intracranial progression was, again, not reached.
Still holding strong after 5 years.
Exactly. Sustained control. For Crizotinib, it was 14.6 months. The hazard ratio there was 0.01, an extremely strong signal favoring Lorlatinib.
So let's put that into perspective for someone listening. What's the chance of being free of brain progression after 5 years on these drugs?
With Lorlatinib, the probability was an amazing 98%.
98%.
Compare that to just 16% with Crizotinib.
Okay, that really drives it home. Lorlatinib wasn't just treating existing brain mets effectively. It was also incredibly good at stopping new ones from even starting.
Precisely. That means preserving cognitive function, independence, just a much higher quality of life, potentially for years longer.
A huge deal for patients and their families.
It really is. And it's worth mentioning these fantastic results held up when they look specifically at subgroups like Japanese and Chinese patients within this Asian cohort.
So consistent across the board there.
Very consistent, yeah. Adds confidence to the findings.
And there was something interesting about managing the treatment too, wasn't there? About dose reductions?
Yes, that's quite relevant clinically. So what they found was even if patients needed to lower their Lorlatinib dose, maybe due to side effects, within the first 16 weeks, their median PFS and their time to brain progression still remained not reached.
So lowering the dose didn't seem to hurt how well the drug worked long term.
Exactly. It suggests there's some flexibility. Doctors could potentially manage side effects by reducing the dose without sacrificing that crucial efficacy, which is great news for keeping patients on treatment.
And they didn't find any link between body weight and needing a dose reduction either.
No correlation found there.
Interesting. Okay, so amazing efficacy, especially in the brain. But like you said, every powerful treatment comes with trade-offs. Let's switch gears to the safety profile.
Right. Important to have a balanced view.
Yeah.
And yes, there are side effects to consider.
Did everyone have side effects?
Pretty much. Treatment-emergent adverse events, or TEAs, occurred in 100% of patients in both groups. That's common in cancer therapy.
Okay, but the types of side effects were different.
Very different in many cases. With Lorlatinib, the things you saw much more often were metabolic issues, like hypertriglyceridemia, high triglycerides, that was in 73%.
Well, nearly 3/4.
And high cholesterol, hypercholesterolemia, in 71%. Also, weight gain was common, almost half the patients, edema or swelling, peripheral neuropathy, the tingling or numbness,
Right.
pyrexia or fever, joint pain, hypertension, and also some cognitive effects, like memory issues, in about 25%.
Okay, so a distinct set of issues there. What about Crizotinib?
Crizotinib's profile was more, well, classically chemotherapy-like in some ways.
Yeah.
Much more nausea, diarrhea, vomiting. Over half the patients had those.
The GI stuff.
Exactly. Also, vision disorders were quite common, constipation, and importantly, increased liver enzymes, ALT and AST. That requires careful monitoring.
So different challenges for patients depending on the drug. What about severe side effects, grade 3 or 4?
Lorlatinib did have a higher rate of grade 3 or 4 TEs, 81% versus 62% for Crizotinib.
That sounds concerning initially.
It does, but you have to look at what those severe events were. For Lorlatinib, it was overwhelmingly driven by those metabolic changes we mentioned.
Okay.
Grade 3 or 4 high triglycerides, 34%, high cholesterol, 22%, and weight gain, 22%. While these are serious and need management, often with other medications or lifestyle changes.
They're often manageable, maybe less acutely debilitating than some other severe side effects.
Generally, yes. Compared to things like severe liver toxicity, which can sometimes happen with other drugs, these metabolic issues, while needing attention, often allow patients to stay on the treatment.
Right. What about really serious adverse events or even fatal ones?
Serious AEs, meaning ones requiring hospitalization or considered life-threatening, were higher with Lorlatinib 49% versus 32%.
Okay.
And fatal AEs occurred in 10% of the Lorlatinib group compared to none in the Crizotinib group.
10% is notable. Were they all related to the drug?
That's the crucial point. The investigators considered only 2 of those fatal events in the Lorlatinib arm to be possibly treatment-related. One was acute cardiac failure, the other respiratory failure.
So most were likely due to the underlying cancer or other issues.
That's the interpretation, yes. Still, something to be aware of, but the direct link to the drug was judged to be rare in terms of fatalities.
How often did side effects actually cause patients to stop taking the drug permanently?
Interestingly, despite the different side effect profiles, the rate of permanently stopping treatment because of treatment-related side effects was actually quite similar.
Mm.
Yeah, it was 5% for Lorlatinib and 8% for Crizotinib.
So, suggesting that even with the higher rate of grade 34 events, the side effects of lorlatinib were generally manageable enough to keep most patients on therapy.
That seems to be the case, yes. Doctors were able to manage them, perhaps with dose adjustments or supportive care.
Now, you mentioned high cholesterol and triglycerides with lorlatinib. What about actual cardiovascular events like heart attacks or clots?
This is a really fascinating finding. So the overall rate of any cardiovascular AE was actually pretty similar between the two groups, 27% for Lorlatinib, 32% for Crizotinib.
Okay, despite lorlatinib causing more hyperlipidemia.
Exactly. And here's the twist. When they looked specifically at the patients who did develop hyperlipidemia,
Yeah.
the rate of cardiovascular events in those patients was lower in the Lorlatinib group, 27%, compared to the Crizotinib group, 67%.
Wait, lower? Even though lorlatinib caused the high lipids? That seems counterintuitive.
It absolutely does. The study noted this was mainly due to lower rates of ischemic heart disease, things like heart attacks, and also lower rates of blood clots, thrombotic and embolic events in the Lorlatinib group among those with hyperlipidemia.
Why would that be? Any theories?
The paper doesn't give a definitive answer, but it raises a really important question. Maybe there's something about lorlatinib's mechanism, or how it interacts with lipids, or perhaps the management of the hyperlipidemia itself was different. It suggests a complex relationship that needs more research. It's definitely not what you'd immediately expect.
Huh. A protective effect, almost. Very strange. Okay, let's move on to biomarkers. How does this help us understand who might benefit most?
Right. The biomarker analysis gives us deeper insights. They looked at specific genetic features of the tumors, like the EML4.ALK variants, specifically types 1 and 3, and also the status of the TP53 gene mutation.
And what did they find?
Lorlatinib showed higher response rates and that not reached PFS across the board, including in patients who had these specific biomarkers.
What's the significance of those particular biomarkers?
Well, often variants like EML4.ALK-V3 or having a TP53 mutation are associated with a poor prognosis, maybe more aggressive disease or resistance to earlier treatments.
So the difficult to treat cases.
Exactly. The fact that lorlatinib performs so well even in these tougher subgroups suggests it's particularly effective, maybe at overcoming some of those resistance mechanisms. It hints that it could be especially beneficial for patients predicted to have a worse outcome otherwise.
So potentially helping us identify patients who stand to gain the most from this specific drug.
Precisely. It points towards more personalized treatment selection down the line.
Now, we should be fair and talk about the study's limitations. Every study has them.
Absolutely, it's important context. As you mentioned earlier, this was a post-hoc subgroup analysis.
Meaning they decided to look at this Asian subgroup after the main study was already running, not as the primary plan.
Correct. And the total number of patients in the subgroup analysis was relatively small, 120 patients total, split between the two drugs.
So the findings are more descriptive. We can't make super strong statistical claims just based on this subgroup alone.
That's right. The results are highly suggestive and align with the main study, but technically they're descriptive due to the post-hoc nature and sample size. Also, one other methodological point. After the 3-year mark, the tumor assessments were done by the local investigators rather than a central blinded review.
Okay, so worth keeping those points in mind.
Definitely. But even with those limitations acknowledged, the data are just remarkably consistent. The size of the benefit with lorlatinib, particularly the PFS and the intracranial control, is so substantial and consistent across different measures that it really reinforces the overall conclusions. The limitations don't really undermine the core message.
Right. The signal is just that strong. So let's bring it back to the listener. What's the big picture here? What does this all mean for you, whether you're deep in the medical field or just really curious about where cancer treatment is heading?
Well, I think
this 5-year deep dive really cements lorlatinib's place, doesn't it? That unprecedented, still not reached, median progression-free survival, both overall and crucially, in the brain, specifically shown here in Asian patients, but mirroring the global results.
Exactly. It confirms the long-term, durable benefit. And importantly, over this extended 5-year follow-up, no new safety red flags popped up. The safety profile seems consistent over time.
So a known profile, Manageable for most.
That's the picture, yes.
Okay, final thoughts. What should people take away from this?
I think this study is a powerful illustration of precision medicine truly working. For this specific group, ALK-positive NSCLC patients, we're seeing a potential transformation.
From aggressive disease to
Potentially something much more manageable long-term, a disease where brain metastases, a huge source of fear and disability, can be controlled effectively for years in many patients.
maintaining quality of life.
Absolutely. And that invites a broader thought, doesn't it? What does this kind of sustained disease control really mean? It's not just about survival statistics. It's about giving people back years of relatively healthy life, allowing them and their families to plan to live, not just constantly battle their illness. It redefines hope in a very tangible way.